Now, moving on to our third section, that is the repair of fractures. In this section, we will be briefly going through what is union, what is delayed union, and what is non-union, and what is the general management of non-union, especially if it's septic or aseptic. So, what is union? Fracture repair is a continuous process. As I told you, remodeling may take up to 1.5 or 2 years at times as well. So it's initially there is either the callus formation or there is bony callus forms. Even it's hard, but it's not completely repaired. Once that has happened, then unsheathing callus is calcified. From the soft callus becomes bony callus or hard callus. Then what happens is the fracture side at this time, once the bony callus or hard callus is formed, usually it's painless on palpation and there is painless on weight bearing as well. But if there is some delay in this union, this process will take more time and this will result to more pain, especially during movement and weight bearing. Then X-ray usually show a bridging callus in which, although the bone is not completely united, but is on good progress to unite. Fracture line, which may be completely or almost obliterated at this time when the bony callus has been formed. From this bony callus starts the remodeling process. The remodeling process is actually laying down of bone over bone so that the eventual strength which was present in the bone before it got fractured can be achieved. Now, once this remodeling process has completed, then we call it that remodeling has completed. Now the union has occurred, and usually on minimum it takes around 9 months. And by the time of 9 months, if the bone has not united, then only we either label it a delayed union or non-union. So what is delayed union? You probably would be knowing it by the names, but definition, healing not occurring at the expected days is termed as delayed union. Efforts usually are done to enhance the healing, which is, for example, this could be related to giving stimulus in form of diet, in form of drugs which can stimulate the bone. And these are usually done so that the union can be enhanced. Usually this fractured limb has some degree of local swelling. There is some degree of pain on movement, and especially if it's the lower limb, there's pain on the weight bearing as well. Now coming to non-union. Non-union is that the fracture has failed to unite. For example, a fracture that is not healed 9 months post-operation, there is no visible progress of healing during the last 3 months. So this is the kind of a window. If it has been more than 9 months and the fracture has not united, you can label it easily as a non-union. But if it's before 9 months and the last 3 months there is no progress over the last x-rays of the fracture being in the progress of uniting, then probably we can still label it a non-union, because if it is not proceeded well in the last 3 months, probably it's not going to proceed well till 9 months is achieved. So classically example, if you see this was probably tibia of somebody, and if you see the fracture line is very much present in between, although there is swelling and there is hypertrophic type of a non-union, but you can appreciate that the fracture line is very well present in. If you see this is again, we can very well appreciate that between the two ends of the humerus, there's an atrophic type of a non-union which can be easily seen. This causes could be aseptic, that is without associated infection, or could be septic. Now, cause of aseptic means mechanical instability. For example, the implant which was chosen was not good enough, or the rigid fixation was not rigid enough, or there is impaired vascularity. Probably what happened is that periosteum was stripped too much, or probably the patient had some kind of vascular disease as well, so there was impaired vascularity as well. This may lead to aseptic type of non-union, that there is non-union, but actually the problem is with either the surgeon or with the patient's vascular system. And there is septic type of non-union. Rigid fixation was good, patient's treatment was good, there was no problem with the vascular, but the patient implant got infected. Now this kind of a scenario means the septic non-union, even with the best rigid fixation methods and proper fixation techniques, still can have a septic non-union. This is very common, especially in the case of patients who are suffering from autoimmune diseases or diseases such as diabetes mellitus. They usually suffer from septic non-unions, and this is because that infection has actually resulted in non-union over the area, and eventually this leads to implant failure, whether it was nail or it was plate. So types of non-union, this could be, as I told you, it could be aseptic, which is not associated with infection. This could be due to the problem with the implant sometimes, that a wrong implant was used, a wrong technique was used, in which either it was too stiff, too rigid fixation, or too mobile, or too flexible fixation, which also leads to, if it was too stiff, this may lead to atrophic type or oligotrophic type of non-union. If it's too mobile, there's a lot of movement at the fracture side, this may lead to hypertrophic type of a non-union. Mobile ones usually lead to either pseudoarthrosis, as you can appreciate it over here, or it leads to hypertrophic type of non-union. And if it is too stiff, there is very little movement at the fracture side, this leads to atrophic type of a non-union. Now coming to the general management, usually what happens is, in case of a non-union, we have to go through different mechanisms. The important point is that you have to take out if it is septic non-union, you have to remove the sepsis first, and we may have to go for if there is a nail or plate which got infected, we may have to remove the implant as well. Then we have to get rid of the bone first, so that the bone first gets microorganisms which are present in the bone and get ridden off, and then once the microorganisms are removed, then we can probably think of all the, once the dead tissue is done, then probably laser off is a good option for bone transport. Classical example is what happens in the tibia. If there is a non-union, and especially a septic type of non-union, then we may have to, during the debridement phases, we may have to take a lot of bone as well. And when post debridement, there is not only the necrotic tissues removed, there is a lot of bone which has to be removed as well, because that has got infected and there's sequestrum formation over there. So there is actually some degree of bone loss. So that can also be covered by use of Lazaroff when we are dealing with septic type of non-union. In this section, we have briefly gone through what are the different types of non-union, especially one is the aseptic type and the septic type. Septic type, in which the microorganisms infect the area, which may lead to implant loosening, and eventually the implants may have to be taken out, and Lazaroff may have to be used for eventually getting rid of the sepsis first, and then using Lazaroff for bone transport. Aseptic type is usually, sometimes the surgeon is at fault as well, because the rigid fixation was not done properly, or there was not proper technique was not applied when fixing the fracture fragment. Or there may be a vascular problem as well, that there is not enough vascular supply over there to cause healing. Therefore, this may also lead to oligotrophic or atrophic type of a non-union. We may have to eventually redo the whole procedure. Thank you very much. Keep watching sqadia.com.